Okay, let's unpack this. Imagine a field of medicine where surgeons don't just, remove disease, but they literally sculpt and rebuild the human body,
Hmm.
restoring not just how it looks, but critically how it works.
Yeah, function is key.
Think about the precision needed to reattach a severed hand, or the artistry to reconstruct a face after some awful accident.
Or even restoring a child's smile. It's really profound.
Exactly. It's the specialty that sits right at the intersection of science, art, and just incredible technical skill.
It truly is. And that's the world we're taking a deep dive into today. Plastic and reconstructive surgery. And immersing ourselves in some really comprehensive source material on this.
Yeah, stuff that really unpacks this whole surgical discipline, right? Covers the history, the techniques, the
The
anatomy.
anatomy, and even looks ahead to the future. It's quite a scope.
So our mission with this deep dive is to really get a handle on this field. We want to move past that common public idea, the one that just focuses on cosmetic stuff,
Right. Which is only part of the picture. A
Yeah.
small part, sometimes.
and really understand the core mission of reconstructive plastic surgery, exploring the concepts, the building blocks.
The sheer complexity, yeah.
Yeah.
How they manage to restore both form and that vital function for patients.
Exactly. Understanding the craft, at a really deep level.
And to truly grasp what this is about, we kind of have to start with the definition. The sources are clear. It's a surgical discipline focused primarily on restoring form and function.
Making things whole again, both appearance and capability.
Precisely.
It's interesting, the name itself, plastic surgery. You might think artificial materials, right? Like plastic implants.
Yeah, that's the common association.
But the word plastic actually comes from this ancient Greek word, plasine. It means to mold or to shape.
Oh, okay.
So it's not about artificiality, it's about shaping living tissue. Skin, muscle, bone, nerve,
Yeah.
whatever's needed.
That makes so much sense. Shaping the body's own materials, using its ability to heal, guided by the surgeon.
Right, it highlights the core of the work.
And here's something else unique that sets it apart from, say, cardiology or urology.
Mhm.
It's not defined by a specific anatomical region. A plastic surgeon might work on a hand one day, a face the next.
A leg the day after. Okay, so what defines it then if it's not a body part?
It's defined by the techniques, the methods they use to reconstruct tissues. Moving tissue, reshaping it, repairing it.
Ah, okay. It's about the how, not the where.
Exactly. That's what gives it such a wide scope. They're basically problem solvers for tissue defects, wherever they occur.
And the need for this kind of reconstruction, it comes from all sorts of things, doesn't it? Not just accidents.
No, absolutely. The sources detail a whole range. You've got congenital issues, things people are born with, like cleft lips or palates, missing fingers.
Right.
Then the aftermath of severe infections that have destroyed tissue. Major trauma, of course, burns, car crashes, work injuries. That's a big one.
And cancer surgery must be a huge area, too.
Huge. Dealing with the defects left after removing tumors, especially big ones in tricky places like the head and neck.
Wow.
And yeah, even the effects of aging, which can sometimes lead to tissue loss or functional problems that need reconstruction.
Because they deal with so many different types of problems, it makes sense they have to be really good collaborators. They're often called in after someone else has handled the main issue.
Precisely. Our sources really stress this collaborative nature. They work with head and neck surgeons, orthopods fixing complex fractures.
Orthopods, right. Covering exposed bone or metalwork.
Yeah, urologists, pediatric surgeons, gynecologists, general surgeons, dermatologists. The list just goes on.
So the plastic surgeon is often the crucial final step, rebuilding the soft tissues, getting things covered, and working again.
Often, yes. They provide that final piece of the puzzle after the initial problem is dealt with.
And it's the development of these modern techniques that's really allowed other fields to advance too, isn't it? Like those major cancer surgeries.
That's a critical point. Think about huge head and neck cancer removals or complex limb reconstructions after severe open fractures.
Yeah.
These became possible, or at least had much better outcomes, because plastic surgeons figured out how to cover the massive defects, protect the vital structures, and restore function.
So without plastic surgery, some life-saving operations just wouldn't be feasible.
Exactly. Modern techniques, especially microsurgery, really push the boundaries of what was surgically achievable overall.
Okay, let's touch on the elephant in the room, aesthetic or cosmetic surgery. The public hears plastic surgery, and often thinks just that.
Yeah, it gets a lot of media attention. It's unavoidable. And the sources acknowledge there's definitely overlap in the techniques.
Like what kind of techniques?
Things like liposuction, fat grafting,
Mm.
knowing how to manage scars, using tissue expanders, shaping flaps. These are tools used in both cosmetic and reconstructive work.
So they share a toolbox in many ways, but what's the fundamental difference according to the sources?
The key distinction, and it's crucial, is that reconstructive plastic surgery also explicitly aims to restore function.
Right, not just appearance.
Exactly. Aesthetic surgery is primarily focused on improving form and appearance, often modifying existing structures. Reconstructive surgery is about rebuilding what's missing or damaged and making it work again, while also aiming for the best possible aesthetic result.
That functional restoration part is just, wow. The sources give some powerful examples.
I really do.
Like someone with facial paralysis, maybe from a stroke or injury, can't smile, maybe their eye won't close.
Yeah, it's devastating functionally and emotionally.
And a reconstructive surgeon might do what is it? A free neurotized gracilis muscle transfer
That's one option, yes. Taking a small muscle from the thigh, the gracilis.
with its blood vessels and nerve.
Exactly. Transferring it to the face, meticulously reconnecting those tiny vessels under a microscope and hooking up the nerve to a facial nerve.
So the hope is the nerve grows in, the muscle starts working.
And the patient can smile again.
Yeah.
It's restoring a fundamental human expression, not just tweaking appearance.
Incredible. Or someone after throat cancer surgery struggling to swallow.
Right. A jejunal-free flap, taking a segment of small intestine with its blood supply.
Small intestine, wow.
Yeah, and using it to reconstruct the pharynx or larynx. It can literally give someone back the ability to eat normally, restoring a vital, life-sustaining function.
You hear examples like that, and it really hits home how life-changing this field is, way beyond just cosmetics.
Absolutely. And these really advanced procedures, especially moving tissue with its blood supply, they built on some foundational discoveries.
Like what?
Well, the sources point out that the microsurgical techniques first developed for moving tissue within the same person autografting and for replanting severed limbs or fingers. Those were fundamental.
So being able to reconnect those tiny blood vessels under a microscope was the key.
That was the technological leap needed. And those developments, especially in the second half of the 20th century, combined with the discovery of immunosuppressant drugs.
Drugs to stop the body rejecting tissue.
Exactly.
Yeah.
That combination paved the way for something truly remarkable: composite tissue allotransplantation.
Okay, break that down. Sounds complicated.
Composite tissue allotransplantation, or homografting, tissue from one human to another, means transplanting multiple tissue types together: skin, muscle, bone, nerves, blood vessels, all as one unit.
Like face transplants or hand transplants.
Precisely. Those are the prime examples: face, hand, even abdominal wall transplants. It's the meeting point of advanced microsurgery and effective immunosuppression that made these things clinically possible, pushing reconstruction into totally new territory.
That's just mind-blowing. It makes you wonder about the history. It must be ancient, right? Driven by the basic need to fix injuries.
It is. While modern plastic surgery as we know it is relatively young, maybe coalescing around World War I, the roots go back millennia, treating injuries from war, accidents, burns, even things like judicial mutilation. The need has always been there.
So where did it start? The sources talk about a pre-scientific period.
Way, way back. Ancient India, around 600 BCE. A surgeon named Susruta described facial flaps, even a way to repair split earlobes, remarkably advanced for the time.
Predating European techniques by centuries.
By centuries, yeah. Others contributed too, of course. Celsus in Rome, around 25 CE, described nasal flaps. Al-Zarawi in Spain, around 1000 CE, worked on lip flaps, sutures, instruments. The Branca family in Sicily, around 1400 CE, used arm flaps for nose reconstruction. Early days, but the concepts were forming.
Okay, then came the scientific period. What was the big change?
From the mid-15th century onwards, it was really driven by a better understanding of anatomy, thanks to human dissection becoming more accepted.
And the printing press helped spread that knowledge.
Passively, anatomical drawings and descriptions could be shared accurately and widely. This allowed knowledge to build.
Who were the key figures then?
Gaspard Tagliacozzi stands out. He popularized what's known as the Italian rhinoplasty in the late 16th century.
What did that involve?
It built on earlier ideas, using a flap of skin and tissue from the upper arm. It was attached to the nose defect, but kept connected to the arm for weeks while the new blood supply grew in.
Wow, so the patient's arm was strapped to their face.
For weeks, yes. A challenging two-stage process, but revolutionary for reconstructing noses at the time.
Gives you perspective. Okay, let's jump to the modern period, 19th century onwards. Things really speed up here.
They do. A much deeper understanding of skin circulation, the blood supply started to emerge. Though, interestingly, some key early work, like Manchet's mapping of vascular territories in the late 19th century, took almost 100 years to be fully appreciated and applied.
And understanding blood supply changed how flaps were designed.
Completely. Those earlier random pattern flaps, like the tubed pedicles used by surgeons like Filatov and Sir Harold Gillies.
Gillies, a pioneer from World War I, right? Reconstructing facial injury.
Exactly, a father of modern plastic surgery. His tubed flaps were ingenious, but were largely replaced by axial pattern flaps,
Axial pattern, meaning
based on a known specific artery and vein. Much more reliable blood supply. Allowed for bigger, safer tissue transfers. Tansini using a latissimus dorsi flap for breast reconstruction back in 1896 is an early example.
And you can't talk about plastic surgery's progress without mentioning other medical breakthroughs happening at the same time.
Oh, absolutely crucial. The sources hammer this home. Antisepsis Semmelweis, Lister cutting down infection rates that made long surgeries deadly.
Right, and anesthesia.
Anesthesia, thanks to people like Morton, allowed surgeons the time to do complex work without inflicting agony. Then antibiotics Fleming to treat infections.
And immunosuppression, as you mentioned, for transplants.
Exactly. Hench, Callain, and others. Without controlling pain, infection, and rejection, complex reconstruction just wasn't possible.
It was a convergence of discoveries.
Totally. And the sources call the last 50 years an explosion, especially microsurgery, leading to things like composite tissue transplants becoming routine almost.
That timeline in the source material really maps it out. Ancient wound care, Tagliacozzi.
And the key concepts like axial patterns from wood, man-taught circulation work, finally getting recognition.
Carroll's Nobel for vascular stitching, the World War I surgeons. Then the microsurgery boom.
Yeah, Cobbett's first toe-to-hand transfer in '68, amazing functional potential. Daniel and Taylor's free groin flap. Taylor's angiosome concept in '78 that was huge changed everything.
How so? The angiosome concepts.
It defined these 3D blocks of tissue supplied by specific arteries. Suddenly, surgeons had a map, a scientific basis for designing reliable flaps.
Okay. Then Yang's radial forearm flap, Koshima's perforator, flaps even more refinement.
Refining it down to single vessels punching through muscle or fascia, and then the big transplants. Dubernard's hand, Duchel's partial face, Barrett's a full face.
It's an incredible lineage of innovation, each step building on the last.
Absolutely. Shows how understanding basic science, like blood flow, and developing tech, like the microscope, directly creates new surgical possibilities.
Which brings us right back to the fundamentals. One of the most basic building blocks, the skin. It's way more than just a covering, isn't it?
Oh, far more. The sources stress it's the body's largest organ, part of the integumentary system with hair, nails, glands. And its functions are critical for survival.
Like what? What are the key jobs?
Well, number one is protection. A mechanical barrier, thermal barrier, UV shield, and crucially, defense against infection. Bacteria, viruses.
Keeps the outside out and the inside in.
Pretty much. It's vital for homeostasis, preventing fluid loss, regulating body temperature through sweating and blood flow changes. It's a massive sensory organ touch, pressure, pain, temperature sensors everywhere.
And it makes vitamin D.
Yep, involved in producing vitamin D with sunlight exposure.
Yeah.
So yeah, it's doing a lot.
So when skin is damaged or lost, you lose all that. Makes sense that restoring the skin barrier is often priority number one in reconstruction.
Exactly. You need that initial protection, stop infection, stop fluid loss, even if deeper stuff needs fixing later.
Let's dig into the structure. The sources mention layers.
3 main ones. Outermost is the epidermis, derived from ectoderm in the embryo. Its deepest layer, the stratum basal, has stem cells making keratinocytes. These cells move up, flatten, fill with keratin, and become the tough, dead outer layer, the stratum corneum. That's the main barrier.
And it can regenerate.
Yeah, from the basal layer and also from stem cells and hair follicles and sweat glands deeper down. That's why superficial burns can heal if those are intact.
Okay, under the epidermis.
That's the dermis, derived from mesoderm. It's thicker, gives structural support. 2 layers here, upper papillary layer, looser tissue, and deeper reticular layer, dense connective tissue, lots of collagen.
And this is where a lot of the machinery is.
Exactly. Hair follicles, oil glands, sweat glands, sensory receptors, and crucially for us, the blood vessels. A rich network.
And the deepest layer?
The hypodermis, or subcutaneous tissue. Mostly loose connective tissue and fat. Contains larger blood vessels and nerves supplying the upper layers, plus the base of hair follicles and glands. It's insulation, energy storage, padding.
And the sources say skin isn't the same everywhere.
Not at all. Big variations. Thickness, hair density, glands, fat content. Compare your palm skin to your eyelid skin. Totally different.
And that variation impacts reconstruction.
Hugely. Rebuilding specialized skin like the scalp or the sole of the foot is tough because donor sites with similar properties are rare.
But other areas are good donor sites.
Yeah, like the abdomen or groin. Skin there is often thinner, more elastic, and you can usually close the donor site directly, which is a big plus.
And for techniques like grafts and flaps, understanding the blood supply is just absolutely fundamental.
It's the bedrock, especially for flaps. The vessels run in networks, plexuses in the dermis and hypodermis. They get their blood from deeper source arteries via these fine perforating vessels.
The perforators punch through fascia or muscle.
Exactly, like little feeder lines coming up to supply the skin.
And this leads back to Taylor's angiosome idea we mentioned.
Yes, 1978 game changer. An angiosome is that 3D block of tissue, skin, fat, maybe muscle or bone, all supplied by one specific source artery.
Yeah.
And the core principle, if you identify that territory and keep its artery intact, you can lift that whole block as a flap, and it brings its own robust blood supply with it.
So mapping these territories revolutionized flap surgery. It gave it a scientific basis.
Absolutely. Predictability, reliability, bigger flaps. And speaking of anatomy, the sources mention cutaneous nerves too. They tend to run alongside vessels.
Can you reconnect nerves in a flap?
You can try. It's called neurodization. Carefully aligning and joining nerve endings in the flap to nerves at the recipient site. Coaptation is the term, not anastomosis like vessels.
Does it restore sensation?
It offers the potential for the flap to regain some sensation over time. Not guaranteed, but possible. Important for protection function.
Now, all this intricate surgery, grafts, flaps, it all hinges on the body's ability to heal, right? Wound healing is the foundation.
It's everything. Every procedure banks on that potential, and surgeons actively manage it. The sources talk about two main ways wounds heal: primary and secondary intention.
Primary intention, that's the usual surgical closure. Stitches, glue.
It's exactly. Bringing the edges together soon after injury. Clean wounds. The goal is fast healing, minimal scarring.
And they mentioned designing incisions along lines of relaxed skin tension.
Yes, especially on the face. These lines show the natural tension. Cutting parallel means less pull on the scar, usually results in a finer line. Cutting across them, more tension, often a wider scar.
Okay, and secondary intention.
That's leaving the wound open to heal from the base up. Keep it clean, dressed. It fills in with granulation tissue. Then skin cells migrate across from the edges.
Granulation tissue, that's the beefy red stuff.
That's the one, the scaffold for new tissue. And the edges pull inwards too, that's contraction.
When would you let a wound heal like that?
Usually for wounds with poor healing potential, like some chronic leg ulcers, pressure sores, or heavily contaminated wounds, maybe animal bites. Closing them surgically might just lead to infection or breakdown. Secondary healing lets the body clean house first.
This brings up that phrase, rob Peter to pay Paul. Plastic surgery often means making a new wound, donor site, to fix the original one.
Yes, a critical point. So the surgeon has to consider the patient's ability to heal both wounds. Maximizing healing potential everywhere is key.
Which means looking at factors that can mess up healing.
Definitely. The sources list several big ones. Genetic conditions affecting connective tissue, like Ehlers-Danlos or epidermolysis bullosa, makes tissues fragile. Surgeons have to be super cautious first, do no harm. Surgery could make things worse.
And general health problems.
Huge impact. Diabetes, especially poorly controlled bad circulation, nerve damage, peripheral vascular disease, poor blood flow. Kidney failure, long-term steroid use suppresses healing. Immunodeficiency means high infection risk.
So getting those things under control before surgery is vital.
Absolutely essential. Optimizing blood sugar, maybe angioplasty for circulation, correcting nutritional issues.
Nutrition is key for building blocks, right? Protein, vitamins.
Crucial. Need the raw materials for repair, often involves a dietitian.
And smoking gets singled out.
Strongly. Smoking constricts blood vessels, cuts oxygen delivery to tissues, directly messes with healing. Higher risk of graft failure, flap loss, infection. Patients really need to stop, ideally 6+ weeks before surgery.
Beyond the patient's overall health, the wound itself needs optimizing.
Often, yes. Formal debridement, cutting away dead or infected tissue. Thorough washout to reduce bacteria. Reduces infection risk. Perioperative antibiotics often used too.
But even with the best prep, healing can go wrong, like abnormal scarring.
Yeah, scarring is normal, but sometimes it's excessive or problematic. Genetics, tension, infection play a role. Two main types of bad scars are described.
First, hypertrophic scars.
Right. These are raised, red, often itchy, appear relatively soon after injury. Key thing. They stay within the original wound boundaries, common over joints, areas of tension.
Do they get better?
Often, yes. They tend to subside over time. Respond reasonably well to treatments like silicone sheets, steroid injections into the scar, pressure garments, sometimes surgery if needed.
And the other type, keloids. They sound worse.
They generally are. Keloids grow beyond the original wound borders, invading normal skin. Can be itchy, painful, keep growing for months or years.
Where do they tend to form?
More common in darker skin tones, typical spots, earlobes, shoulders, chest, posternal area, sometimes face. Much harder to treat. High recurrence rate even after cutting them out, often need combination therapy, excision, plus maybe radiation or freezing.
Are there other scar problems besides those two?
Sure, scars can be wide, thin, depressed, often from too much tension or not enough tissue underneath. Unstable scars are another issue prone to breaking down, especially in mobile areas or after secondary healing. Might need revision surgery, maybe even a flap for better coverage.
What about problems during healing in the wound bed itself?
Overgranulation can happen. Too much of that beefy red granulation tissue. It gets unstable, bleeds easily, stops the edges closing. Needs treatment, maybe silver nitrate or cutting it back.
And pyogenic granuloma, the sources have a picture.
Yeah, that's a benign blob, basically an overgrowth of capillaries.
Yeah.
Looks like a little red nodule, grows fast, bleeds easily if not, often pops up after minor injury, usually needs removing.
Then there's the really serious one related to chronic wounds, marginal ulcer.
Very important, though rare. It's an aggressive skin cancer, squamous cell carcinoma, that develops in a long-standing, non-healing wound.
Like in old burn scars or pressure sores.
Exactly. Chronic inflammation is the trigger. High risk of spreading, metastasis. The key takeaway. Any change in a chronic wound, sudden growth, pain, bleeding, needs urgent biopsy to rule this out. High index of suspicion needed.
A sobering reminder. Managing these wounds effectively is critical. Part of that is using the right dressings.
Dressings aren't just passive covers, they're active tools to create the best healing environment. The sources list ideal properties.
Like what?
Maintain moisture, allow gas exchange, block bacteria, non-stick, sterile, non-toxic, non-allergenic, and ideally available and affordable. It's a tall order.
Sounds like complex material science. What are some common types?
Lots of options. Depends on the wound. Simple gauze with petroleum jelly, like Gelinette, for clean, dryish wounds. Semi-permeable foam, Alevine, for moderate to heavy drainage, absorbs fluid but keeps it moist. Hydrocolloids, Duoderm, form a gel, good for light drainage like donor sites.
Any others?
Alginates, Cultistat, from seaweed, good for heavy drainage or bleeding, they form a gel. Silicone sheets, Mepitel, are super non-stick, great for fragile skin or kids. And antimicrobial ones with silver, Acosel Aga, or inodine for infected wounds.
Then there's the more advanced technique, negative pressure wound therapy, VAC therapy.
Yes, vacuum-assisted closure. You put special foam in the wound, seal it with film, and apply suction with a pump, usually around Medicate 125 mmHg.
How does sucking on a wound help it heal?
Multiple ways. Mechanically pulls edges together, stimulates granulation tissue growth, sucks out excess fluid, and exudate, reducing swelling and bacteria. Basically cleans and encourages healing.
Sounds very useful. Where's it used?
Lots of places. Great for holding skin grafts down firmly. Temporary cover for complex wounds, like an open abdomen after trauma, protects organs. Really good for managing chronic wounds like pressure ulcers, gets them ready for closure.
So once the wound bed is ready, the surgeon picks the reconstruction method. It's a whole spectrum, right?
Absolutely. From just letting it heal, secondary intention, or simple grafts, all the way up to complex free flaps, moving tissue with its blood supply, or even transplants from donors.
Using different materials, too.
Yeah, mostly the patient's own tissue, autologous, that's best, no rejection. But sometimes allografts, other human tissue, synthetics like titanium or Medpor, fixators, tissue expanders.
And again, understanding that blood supply anatomy was key to developing more options.
Totally. Knowing about angiosomes, perforators, led to better flaps. But the real game changer was the operating microscope, enabled microsurgery.
Letting surgeons connect tiny things they couldn't even see properly before.
Exactly. That ability to do microvascular anastomosis, connecting tiny blood vessels, is what made free tissue transfer and replantation possible.
Before microsurgery, you were limited by how far a flap could reach on its own stalk, its pedicle.
Right. Microsurgery meant you could detach tissue with its blood supply from anywhere, move it, and reconnect the vessels at the new site. Total freedom.
Bringing healthy, vascularized tissue to places with poor blood supply, like exposed bone.
Precisely. It's not just coverage, it's bringing life support to the area. The goal is always better healing, avoiding chronic wounds, bad scars, deep infection.
And the usual starting point is a defect too big to just stitch closed.
Yeah, where primary closure would be too tight, or secondary healing would give a bad result, or a graft just wouldn't survive.
The sources mention this old idea, the reconstructive ladder. Simplest first.
Yeah, that's considered obsolete now. Start simple, only go complex if it fails. Not efficient, often leads to worse outcomes.
So what's the modern approach?
It's called the patient-centered reconstructive elevator. You assess the patient, the defect, the needs, your skills, and choose the best technique for that specific situation right from the start. Go straight to the optimal solution.
Can you give some examples of this elevator thinking from the sources?
Sure. Big burns, you need rapid cover. Split-thickness skin grafts are often best, even if they scar because they cover large areas quickly. Speed is key.
What about a defect on the face after cancer removal?
Even if small, you might choose a local flap from nearby facial skin straight away. A graft could work, but the flap gives much better color, texture match, contour. Aesthetics are critical there, so elevator goes straight to flap.
Makes sense. A pressure sore.
Needs dural padding, fill dead space. Graft or simple closure likely fails. So you choose a robust local flap, often muscle or musculocutaneous, right away. It brings blood supply, fills the hole, resists pressure better.
And complex limb injuries. Exposed bone after a bad fracture.
Classic free flap territory. Local tissue is often wrecked. Graft won't take on bone or metal. You need healthy tissue from far away. So a free muscle flap or fasciocutaneous flap brought in via microsurgery to cover everything, fight infection, help the bone heal, often saves the limb from amputation.
Really highlights how tailored the approach is. Okay, let's dive into the techniques themselves. Grafts first. Tissue transferred without blood supply, right?
Correct. They rely entirely on the recipient bed. Need oxygen and nutrients from it. First, by soaking up fluid, imbibition, then new vessels grow in, revascularization and angiogenesis.
So the bed has to be healthy, good blood supply.
Absolutely critical. Poor bed, graft fails. Common failure causes. Shear forces moving the graft. Infection. Strep A is notorious for destroying grafts, or fluid collecting underneath hematoma or seroma lifting it off.
Okay, skin grafts specifically, used when defects are too big for direct closure.
Or when secondary healing isn't good enough. Two main types based on thickness.
Split thickness.
Includes all the epidermis, but only a partial thickness of dermis. Harvested with a dermatome, slices off a thin sheet, usually from thigh, buttock, back.
Good for big areas like burns.
Yep, can harvest large amounts. Can also be meshed, put through a device that makes slits, lets it expand like netting to cover more area. Meshing also lets fluid drain out from underneath.
Downsides.
Less durable than full thickness, tend to contract quite a bit as they heal, which can be a problem over joints. The donor site heals like a graze, usually in about 2 weeks, because some dermis and skin elements are left behind.
So the alternative is full-thickness grafts. Wolf grafts.
Right, epidermis plus the entire dermis. Because they have the full dermal structure, they're more elastic, contract much less, generally look and feel better.
But you can't take as much.
Exactly. The donor site has to be stitched closed directly, so you take them from areas with a bit of spare skin, above the collarbone, groin crease, behind the ear, upper eyelid.
Where are they typically used?
Smaller defects where quality matters more than quantity. Releasing webbed fingers, facial reconstruction after skin cancer, releasing burn contractures over joints or face.
And composite grafts? Skin plus something else.
Yeah. Skin plus cartilage is common, like taking a bit of ear rim, skin and cartilage for a nose defect. Cartilage gives shape, skin gives cover. Or maybe a scalp graft with hair follicles for an eyebrow.
Beyond skin, what else gets grafted?
Nerves. Nerve grafts bridge gaps and damaged peripheral nerves. Need careful alignment coaptation so nerve fibers can grow across. Common donors: sural nerve, calf, medial antebrachial, cutaneous, forearm. Used for brachial plexus injuries, facial palsy, restoring
Your
sensation.
tendons too?
Yep, for gaps in tendons after trauma or disease, common donors. Palmaris longus, forearm if present, tendons from the foot.
And cartilage.
Autologous cartilage, patient's own for support, shape, joint repair. Ear cartilage, concha, nasal septum, rib cartilage, costal. Used for ear reconstruction, microsurgical, building up the nose bridge, fixing hand joints, or TMJ.
What about using tissue from other people or species? Allograft, xenograft.
Sometimes used when autograft isn't feasible, not enough donor tissue, or patient too unwell for donor site surgery, usually temporary. Cadaver skin, allograft, or processed pig skin, xenograft, can be used as temporary dressings on massive burns or necrotizing fasciitis, protecting the wound until the patient is stable enough for their own skin grafts.
And manufactured skin substitutes.
Engineered dressings try to mimic skin functions, can be cellular or acellular, replace epidermis, dermis, or both. Examples like Alloderm, Integray, Episol, Epigraph.
Pros and cons.
Pro, available off the shelf, no donor site wound. Con, expensive, often need very careful wound prep and application to work well.
Okay, shifting gears. Instead of just moving tissue, sometimes you can create more tissue first. Tissue expansion.
Exactly. Clever technique. Uses a subcutaneous balloon expander.
How does that work?
You surgically place a deflated silicone balloon under the skin near the defect. It is a small port. Over weeks or months, you inject saline into the port, gradually inflating the balloon.
Stretching the skin over it.
Pretty much. It takes advantage of skin's viscoelasticity. It stretches and then permanently elongates stress relaxation. The stretching also stimulates new blood vessel growth, angiogenesis. A fibrous capsule forms around the expander too.
So you end up with extra well-vascularized skin.
Yes. You create a large flap of tissue that matches the surrounding area in color, texture, hair, etc. Once expansion is done, remove the expander and use the newly created tissue flap to cover the defect.
Where is it used most?
Great for scalp reconstruction, creates hair-bearing flaps. Widely used in breast reconstruction after mastectomy, stretches the skin for an implant. Also used for ear reconstruction, removing large birthmarks, IUV. Can use multiple expanders for really big areas.
Any downsides or risks?
Less predictable or riskier in irradiated tissue radiation damages blood supply and healing. Also potentially problematic in patients with diabetes or connective tissue disorders that impair healing and tissue stretch.
Beyond living tissue, sometimes non-living materials are needed. Prosthetics and implants.
Yep. External prosthetics replace things like eyes, noses, ears, hands cosmetically.
And internal alloplastic implants.
Made from synthetic, biocompatible materials. Titanium plates mesh for skull defects, cranioplasty. Porous polyethylene, MedPor, to build up facial bones, cheeks, chin.
And breast implants are a major category.
Huge. Silicone shell filled with saline or silicone gel. Various shape sizes, smooth or textured surfaces.
Potential issues with those?
Sources mentioned capsular contracture, scar tissue tightening around it. Can interfere with mammograms. And that small risk of BIA-ALCL, a rare lymphoma, especially with textured implants.
Okay, another technique using the patient's own tissue, lipotransfer or fat grafting.
Right, taking fat from one spot, injecting it elsewhere for volume, lipomodeling.
What's it used for in reconstruction?
Filling facial defects, like in Perry-Romberg syndrome. Used in breast reconstruction for contouring or volume. Huge demand in aesthetics too, face, buttocks, breasts.
Any benefits beyond just volume?
Yeah, interestingly, it seems to improve scar quality and tissue health, especially after radiation. Theory is the adipose-derived stromal cells in fat have regenerative potential, modulate healing.
Why is fat seen as a good filler?
It's autologous, so biocompatible, no rejection. Readily available in many people. Cheap to harvest. It can be repeated. Coleman standardized the technique, making it more reliable.
What's the process?
3 steps usually. Harvest, gentle liposuction, belly, thighs, preparation, often centrifuge to purify the fat cells. Injection, carefully placing the fat in layers with fine cannulas.
Main drawback.
Unpredictable survival.
A lot of the transferred fat can just get reabsorbed by the body. Survival rates vary wildly, like 20% to 80%. Research is ongoing to improve that.
Any serious risks?
Rare. But fat embolism is the big one. Injecting fat into a blood vessel. Can travel to lungs, brain, eyes. Potentially devastating. Needs careful technique.
Okay, let's get to the real workhorses, the most versatile tools, flaps. Tissue moved with its blood supply.
That's the key difference from grafts. Flaps bring their own plumbing, contained in the pedicle, which means they can survive where grafts can't, like on bare bone or tendon.
Exactly. Or over implants. They don't need a vascular bed underneath. They provide coverage, bulk, padding, and crucially bring blood flow to help healing or fight infection.
Sources mention the 5 C's for classifying flaps, a useful system.
Yeah, it's a good framework. Circulation, composition, contiguity, contour, conditioning. Helps break down the different types.
Okay, circulation.
Blood supply pattern. Random pattern flaps rely on the general skin plexus. No specific vessel, limited size. Axial pattern flaps are designed around a known artery and vein. Much more robust, can be bigger.
Composition.
What tissues are in it? Cutaneous, Skin fat. Fasciocutaneous includes muscle. Musculocutaneous, muscle plus skin. Osseous bone, osteocutaneous bone plus skin. Even bowel or omentum flaps exist.
Contiguity, proximity.
Yep. Local flaps are right next door to the defect. Regional flaps are nearby but not touching. Pedicle crosses tissue. Distant flaps are from far away, either pedicled across a distance, less common now, or more often free flaps.
Free flaps, meaning completely detached and reconnected microsurgically.
Exactly. That's the most common type of distant flap today.
Contour how it's moved.
Method of transfer. Advancement, slides forward. Transposition, pivots over tissue. Rotation, pivots a curve. Interpolation, pedicle passes over under, divided later. Free, microvascular transfer. Others too, like waltzing or crane principle, more historical or specialized.
And conditioning.
That's flap delay. Doing a preliminary surgery to partially interrupt blood supply, making the flap train its main pedicle, improves vascularity, lets you safely move a larger flap later. Less common with modern reliable flaps, but still used sometimes.
That 5C system definitely helps. Let's look at specifics. Fasciocutaneous flaps.
Skin, fat, and the deep fascia layer. Fascia adds extra blood supply from perforators coming up from below. More reliable than just skin fat flaps. Cormack and Lamberty classified them based on perforator patterns. Examples: scapular flap, radial forearm, Chinese slack.
And the musculocutaneous flaps, based on muscle blood supply.
Right. Muscle is very vascular. Mathis and Nahai classified muscles based on their blood supply patterns, type I to V. Helps predict reliability. Musculocutaneous flaps include the muscle and an overlying skin paddle supplied by vessels punching through the muscle.
Muscle flaps sound great for filling holes and fighting infection.
Excellent for that. Bring bulk, robust blood supply. Latissimus dorsi flap is a classic example, used for breast reconstruction, covering big limb defects.
What about chimeric flaps? Sounds complex.
It is. It's like assembling multiple different flap components, for example, bone, muscle, skin, that each have their own little blood vessel, but all those vessels branch off one main source artery vein pedicle.
So you only need to connect that one main pedicle at the recipient site.
Exactly. Lets you reconstruct really complex multi-tissue defects with just one set of microanastomoses. Very efficient for intricate reconstructions.
Wow. The sources also mention venous flow-through flaps.
Less common. Based mainly on a vein for both inflow and outflow. Thin, pliable, but prone to congestion because they're waiting for arterial inflow to grow in. Bit tricky.
All these advanced flaps, especially free flaps, rely heavily on microsurgery.
It's the absolute cornerstone. Using magnification, fine instruments, specific techniques for tiny structures.
How tiny are we talking?
Connecting blood vessels often less than a millimeter wide. Sutures finer than a human hair, like 0.01 to 0.03 millimeter, also allows precise nerve coaptation.
Takes incredible skill.
And training. But the impact is huge. Allows free tissue transfer to anywhere. If you can find recipient vessels, you can bring the right tissue. Total versatility.
Main applications where it's made the biggest difference.
Oncological reconstruction head neck. Breast-free flaps like ALT or DIEP give superior results. Complex limb trauma infection, free muscle flaps often save limbs from amputation.
Functional restoration, too?
Big time. Free functional muscle transfers for facial palsy or brachial plexus. Free bone flaps like fibula for jaw or leg bone reconstruction.
And replantation, reattaching severed parts.
Critical application. Reconnecting arteries, veins, nerves microsurgically for fingers, hands, arms. Also reconstructing missing fingers using free toe transfers.
And enabled face-hand transplants.
Yes, vascularized composite allotransplantation depends entirely on microsurgery plus immunosuppression.
How are the vessels actually joined? Always hand-sewn?
Mostly hand-sewn with those tiny sutures. But mechanical couplers are getting popular, especially for veins. Can be faster, maybe technically easier.
And pushing the boundaries even further, super microsurgery.
Working even smaller. Vessels and nerves in the 0.3 to 0.8 millimeter range, used for things like salvaging fingertip injuries or lymphatic surgery for lymphedema.
With these critical blood supplies, monitoring the flap after surgery must be intense.
Absolutely vital, especially for free flaps, usually done in a high-dependency setting. Close nursing surveillance.
What's the goal of the post-op care?
Keep blood flowing to the flap. The mantra is wet, warm, and comfortable. Good hydration. Keep the patient warm to avoid vessel constriction. Good pain control.
How is the flap itself checked?
Nurses check color, warmth, turgor, firmness regularly. Bedside tests like capillary refill press and see how fast color returns. Pinprick test, check for bleeding and what color the blood is. Bright red equals good arterial inflow. Dark, venous congestion, none, big trouble.
Doppler is used too.
Handheld Doppler to listen for arterial pole and venous flow sounds. For buried flaps, sometimes an implantable Doppler probe is placed on the vein during surgery for continuous monitoring.
Main threats they're watching for.
Arterial inflow blockage or venous outflow blockage. Either one can kill the flap quickly.
And if a problem is suspected,
Urgent return to the operating room. Explore the pedicle, find the clot or kink, fix it. Time is absolutely critical for salvage.
what are the stats on flap failure or reoperation?
About 5% of free flaps need exploring. Over 60% of those explored can be saved if caught early. Venous problems are more common than arterial, about 2.1. Sometimes it's external compression hematoma. Tight dressing needs immediate release at bedside.
When's the highest risk period?
First 48 hours are most critical for monitoring.
But overall success rates are high.
Very high in elective cases like breast reconstruction, over 95%. A bit lower in complex trauma or head neck cancer, but still generally excellent.
No, something surprising. Leech therapy. Still used.
Yes, the medicinal leech, Hirudo medicinalis, sounds medieval, but has a specific, valuable niche.
Because of its saliva.
Exactly. Contains hirudin, anticoagulant, hyaluronidase, helps penetration, histamine, vasodilator. Potent stuff.
What's the indication in plastic surgery?
Specifically for venously congested flaps. Flap is blue-purple, blood getting in but can't get out easily. Brisk, dark capillary refill, dark bleeding on pinprick.
Why might that happen?
Maybe the recipient vein was too small or couldn't be connected well. Sometimes in distal replants where fixing the vein is technically impossible, leeches provide temporary outflow.
But not for arterial problems or blocked free flap veins.
Absolutely not. Those need surgery immediately. Leeches are for a specific type of venous outflow issue where surgery isn't the answer or needs help.
How long does it go on for?
It can be up to 2 weeks. Buys time for new veins to grow into the flap from the edges, neoangiogenesis. Then the flap can drain itself. The picture shows it on an ear replant.
Side effects.
Significant blood loss. Leech bite keeps oozing for hours due to hirudin. Needs careful hemoglobin monitoring, maybe transfusions. Also, infection risk leeches carry Aeromonas bacteria. Patients need prophylactic antibiotics, like a quinolone.
Fascinating. And ancient tools still useful.
Okay, looking ahead, future directions, driven by the same things: anatomical understanding, tech innovation, plus aging populations needing more reconstruction. Multidisciplinary approach is key, combining surgery with science.
Key scientific areas.
Wound healing research, bioengineering, better integration with cancer treatments, and improving immunotolerance for transplants.
So basic science discoveries are opening doors.
Yeah, understanding genetics of things like craniosynostosis, clefts, Dupuytren's, poor healing gives targets for new therapies.
Bioengineering and tissue engineering sound huge.
Major future role: smart expanders, biocompatible scaffolds to guide regeneration, maybe deliver drugs locally. Lots of potential.
Cultural shifts playing a role too.
Yes, areas like gender-affirming surgery are evolving rapidly, driving innovation in complex reconstructive techniques.
A composite transplants face, hand still developing.
Definitely. Outcomes improving as immunology and techniques get better. Social acceptance of donation is also a factor.
Robotics.
Expanding role, especially for limited access areas, clefts, deep head neck stuff, eliminates tremor, enhances dexterity, 3D vision.
But challenges remain. Field is very broad.
Huge challenge. Lots of techniques for similar problems, makes high-quality evidence hard to generate. Lack of big randomized trials comparing approaches.
Makes that elevator choice rely heavily on experience and judgment.
Exactly. Critical thinking is vital. Just because you can do a complex operation doesn't always mean you should. Limb salvage versus amputation is a classic example what gives the best quality of life. Needs shared decision-making.
So what's needed to improve?
Better clinical trials, pragmatic ones. Rigorous outcome measures, especially patient-reported outcomes, PROMs. Large research networks to pool data. Essential for evidence-based practice.
So wrapping up this deep dive, what's the big picture?
It's an incredible journey, isn't it? From ancient earlobe repairs to face transplants. From basic skin anatomy to super microsurgery.
And the core mission stays the same, restoring form and function, improving lives after injury, disease, or congenital issues.
It demands this unique blend: science, technical skill, artistry, engineering thinking.
And empathy, understanding the person, not just the defect, restoring their ability to live fully.
Absolutely. It pushes boundaries, makes you think about healing, identity, resilience.
And the future, ethical questions around transplants, regenerative medicine, growing organs. What does it all mean for human health and identity?
It really opens up possibilities. Blurring lines between biology, engineering, robotics, all aimed at restoring human potential.
An extraordinary field. Thanks for joining us on this deep dive.